Ya Allah. Bismillahirrahmanirrahim. Hello dear. Hello. How are you? This is the third lecture in neurology, Unit 8. I gave you, actually this is the last lecture with narration. I gave you two previous lectures, the epilepsy and dementia, and this is the third lecture, Parkinson disease. Okay, you remain with the previous four lectures which I had gave you in the hall in the college. I will send you this lecture as words or PDF without narration. I will only send to you, this is the last lecture with narration. This is about Parkinson disease. It is very easy lecture. The disease can be easily understood. So please listen to me. Now, epidemiology of disease, it's occur around twice as common in men than women, and the mean age of diagnosis about 65 years. Now let us discuss the features of Parkinson's disease. First, bradykinesis. What we mean by bradykinesis? It is a poverty of movement, also seen, sometimes referred to as hypokinesia. The patient has short shuffling steps with reduced arm swinging and difficulty in initiating movement. So bradykinesia as a whole means slowness of movement. The patient has difficulty to start walk, difficulty to end walk, and also there is difficulty in turning. Sometimes the patient when walk, he may have a fascinant gait, that is an increase in the speed, and the patient may fall because the center of his weight is in front of him. The patient had flexed posture. Okay. The tremor is typically pill rolling, that is in the thumb and index finger, and most marked at rest, with low frequency, about 3 to 6 Hz, worse when stressed or tired, and with levodopa. And this is called rest tremor, to differentiate it from other types of tremor, which is intentional tremor, which occur in cerebellar disorders, and the postural tremor, which occur when you want to use your arm or your hands. The third feature is rigidity, and we have two types of rigidity. That is, rigidity means an increased tone. So patients have two types of rigidity: lead pipe, which occur mainly in the lower limbs, and cogwheel, which is due to superimposed tremor. So when you have a tremor with the rigidity, is called cogwheel. It is better seen in the when you examine the wrist of the patient. Other characteristic features of Parkinson's disease include mask-like faces. If you look to the face of the patient, you will never forget it. The patient has mask face with the decreased expressions, decreased blinking of the eyes, greasy face. There is a flexed posture when the patient stands up, micrographia, and drooling of saliva. Drooling of saliva is due to rigidity of and inability to swallow saliva. He have in addition psychiatric feature. Depression is the most common feature, affect about 40% of cases of Parkinson's disease. Psychosis and sleep disturbances may also occur. Impaired olfaction also is a manifestation of Parkinson's disease. Rapid eye movement, sleep behavior disorders, and other non-motor manifestation of Parkinson's disease. If you find diplopia in a patient with Parkinson's disease, this is very uncommon and may suggest an alternative diagnosis such as progressive supranuclear pulse. You have to be careful about the following note, which is difficulty in initiating movement. That's bradykinesia, postural instability, and unilateral symptom initially are typical of Parkinson's disease. This is very important. Causes of Parkinsonism include first Parkinson's disease, which is idiopathic, drug induced like antipsychotics, metoclopramide, and other drugs which I will tell you later on. Progressive supranuclear palsy, multiple system atrophy, Wilson disease, post-encephalitis, dementia pugilistica, secondary to chronic head trauma like boxing. All of us remember the famous boxer Muhammad Ali Clay. Toxin like carbon monoxide, carbon disulfide, MPTP, manganese, and cycadnut. These are the commonest or the common causes of Parkinson's, but idiopathic remain on the top. Drug-induced Parkinsonism, these include phenothiazines, very common, chlorpromazine, that's largectil, prochlorperazine, stimetil, butyrophenone, like haloperidol, droperidol, and metoclopramide. The difference of drug-induced Parkinsonism from idiopathic Parkinsonism or idiopathic Parkinson's disease is different in two main points. The motor symptoms are generally rapid onset and bilateral. Rigidity and rest tremor are uncommon. Domperidol does not, so if you want an antiemetic drug, please don't use stimetil or metoclopramide. Domperidol, that is that is motilium, does not cross the blood-brain barrier and therefore does not cause extrapyramidal side effect. Treatment of drug-induced Parkinsonism is not by L-DOPA or symmetry like amantadine or other. It's treated by anticholinergic. For example, benzoxazole, which is Artane, is the treatment of choice for tremor, predominantly Parkinson's disease. Anticholinergic work mainly on the tremor, while levodopa and dopamine agonists like bromocriptine, ropinirole are the treatment of choice for bradykinesia and rigidity. So Parkinson's disease management, currently accepted practice in the management of patients with Parkinson's disease to delay treatment until the onset of disabling symptom, and then to introduce dopamine receptor antagonists. So when you face patient with Parkinson's disease for the first time, he can walk normally, he can sleep normally, there is no tremor which affect his daily requirement, no need to start treatment, please. The practice is to delay treatment of Parkinson as much as we can, and this is because most of the drug working on Parkinson's disease will lose its effectiveness by time. The first group of drug used to treat Parkinson is dopamine receptor agonists, and these are favored for patients less than 75 years old. Example of these are bromocriptine, gabapentin, apomorphine, ropinirole, and pramipixole. But in the last year, during the research, they found that ergot-derived dopamine receptor agonists like bromocriptine, gabapentin, and pergolide have been associated with pulmonary, cardiac, and retroperitoneal fibrosis. So these drugs are actually not used now to treat Parkinson's disease. Ropinirole is the least associated with tissue fibrosis. So ropinirole is an ergot-derived dopamine agonist licensed for treatment of Parkinsonism and restless leg syndrome. So please remember, ropinirole has two indications. First is Parkinson's disease, second is restless leg syndrome. It is a reasonable choice for first-line therapy in younger patients, that is less than 75 years. The Committee on Safety of Medicine advised that an echogram, echocardiogram, ESR, creatinine, and chest X-ray should be obtained prior to treatment, and patients should be monitored closely. If you choose to treat with the ergot derivative, patients should be warned about impulse control disorder and excessive daytime sleep due to dopamine receptor agonists. This is very important side effect, and especially when you gave them to an elderly patient. more likely than levodopa to cause hallucination in older patients. Nasal congestion and postural hypotension are also seen. Dopamine agonists are thought to be associated with less on and off phenomena than L-dopa and are seen as a reasonable choice for first-line therapy in younger patients. So when a patient on L-dopa, levodopa, and develop the on and off phenomena, on and off mean that the patient sometimes got freezed, that is, he have no any movement, like freeze, complete freeze, and after a while, a time, then he can walk. This is called on and off phenomenon, and this is due to progression of the disease and due to L-dopa. The treatment of this on and off phenomena is by three ways. First, to decrease the doses of L-dopa and increase the frequency, decrease the dose, that is about let's say 1/4 of a tablet every 2-3 hours, then adding dopamine agonist like roperidol or pramipixole, and certain education about exercise and lifestyle of eating. Pirgolide is obsolete drug because of valvular dysfunction. Second drug is the levodopa, favored for patients more than 75 years old. If the patient is elderly, levodopa is sometimes used as initial treatment. That is mean if you diagnose a patient above 65 or above 75, you may start a patient with L-dopa, usually combined with decarboxylase inhibitor, example carbidopa or benserazide, to prevent peripheral metabolism of levodopa to dopamine. You know, if this drug is metabolized peripherally, most of the drug, more than 75% of the drug will be metabolized peripherally in the blood, and it will cause a list or a host of side effects like vomiting, nausea, postural hypotension, etc. So these enzymes will prevent metabolism peripherally and let the drug cross the blood-brain barrier, reaching the neurons. DOPA decarboxylase inhibitor reduce the exacerbation complication of L-dopa therapy. These include nausea, vomiting, postural hypotension, and cardiac arrhythmia. Reduce effectiveness with time, usually by 2 years. So this is the aim of delaying treatment of levodopa. We always aim to delay treatment with L-dopa because it will lose, or it lost its effectiveness by 2 to 5 years. Unwanted side effects of levodopa include dyskinesia, which is involuntary writhing movement, on and off phenomena, psychosis, postural hypotension, cardiac arrhythmia, dry mouth, anorexia, nausea, and vomiting, reddish discoloration of urine on standing. Not use in neuroleptic-induced Parkinsonism. As I told you, if a patient due to metoclopramide antipsychotic develop Parkinson's disease, then the treatment is anticholinergic only. The monoamine oxidase beta type inhibitor like siligilene, previously used as a protective, as antioxidant for neurons, it's substantia nigra. It inhibits the breakdown of dopamine secreted by the dopaminergic neurons. It may use initially alone with another anti-Parkinsonian drugs. The fourth group of drugs is called amantadine. This is originally antiviral drugs. They found its increased release of dopamine from the neurons. Its mechanism of action is not fully understood, probably by increased dopamine release and inhibit its reuptake at dopaminergic terminals. Its trade name called Symetril. Side effects include ataxia, slurred speech, confusion, dizziness, and libido reticularis. It may be used also. It can be used initially with the dopamine receptor agonist, or it can be used also alone initially. The COMT, that's the catechol or methyltransferase inhibitors, also drugs which prevent metabolism of dopamine at the neurons at the terminals, like entacapone or tolcapone. May be used as adjuvant or adjunct to levodopa therapy, used in conjunction with levodopa in patients with established Parkinson's disease. The last group of drugs, which is anti-muscarinic, these drugs are highly addictive, like Artane, Benzixol, like chemodrine, very very addictive, but used in Parkinson disease. You know, in Parkinson disease there is imbalance. We have two systems, cholinergic and dopaminergic neurons, dopaminergic transmitters. In Parkinson, there is highly deficiency of dopamine, so cholinergic neuron seem to be higher than dopaminergic. If we want to balance these, if we want to balance these two systems, we may use anticholinergic. With these drugs are mainly used for tremor. And now used to treat drug-induced Parkinsonism, that's Parkinsonism secondary to antipsychotic medication, used in treatment of schizophrenia rather than idiopathic Parkinson's disease. Also is in treatment of extrapyramidal symptoms, acute dystonic dyskinetic reaction of metoclopramide antiemetic. Most of you noticed a child or a patient taking estimetide or metoclopramide or metoclopramide, other antipsychotic with severe dystonia, torticollis, oculogyric crisis. When we treat this patient, we may give them benzhexol, Artane, or chemodrine. Mainly it helps in tremor, but also it has an effect on rigidity. Famous drug are the benzatropine, brocyclidine, trihexyphenidyl, that is benzhexol. This is the important point actually in the lecture. There is a lot of talk. I imagine that you know something about the pathology of Parkinson's disease. You know the pathophysiology from your previous lecture on physiology and pathology. Please return back to your book, Davidson, about anything you cannot understand. Be free to ask me any question you want. Don't hesitate. I'm with you, and I will help you. Actually, I will after finishing the all the lectures. I told you you have two lectures I have to send to you. That's meningitis. I told you that I discussed this lecture in the hall in the college, and also multiple sclerosis, and another third lecture I don't remember. The whole lectures are 7. Okay, at the end of the lecture I hope you sent me a message to give you a collection of a question you use which help you in the exam. Thank you very much. God bless you all. Be protected. Please keep social distances and wear your mask and gloves when you are in the street because of corona. Don't be ignorant at all. It's a serious disease. Thank you again. Thank you very much. راحت ما ادري وين على هذه
شو الفاضي هي هاد الاكس
على الاكس كلوز